I think as a country, we've been missing the opportunity to leverage state-based infrastructure. CRISP organization is helping very directly advance health data utility in a number of states.
What do you kind of envision CSRI's role to become at that point?
If you're a policymaker, what do you need health data for? If you're a doctor seeing 22 patients today, what do you need health data for? That's one of the challenges, I believe, is that getting health data utilities recognized.
Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. Explore how modern technology can remove barriers and improve care at scale. It's about ditching inertia and building smarter. For insiders, innovators, and anyone ready to navigate what's next, this is your launchpad. Here is your host, Ben Wade.
Welcome to another episode of the Next Orbit podcast. Today we want to explore health data utilities. And I think Mike and I were fortunate enough to land the perfect guide. Our guest today is highly decorated in this field. He's the president and CEO of the Indiana Health Information Exchange, also the former acting CEO of CSRI, which is a consortium of state and regional interoperability. He's served on the board of directors for the Regenstrief Institute, as well as the Sequoia Project, eHealth Exchange Coordinating Committee, and the Office of National Coordinators IT Advisory Committee. Additionally, he served as vice chair of the North America HIMSS Board and co-chaired the High Tech TEFCA Task Force. With that, please welcome John Kansky to the show.
Welcome, John.
Thanks for being here.
No, appreciate it. You guys made me sound pretty busy.
Yeah, it felt like I was introducing Tiger Woods before teeing off in a tournament there for a second.
Not good.
John, thanks again for joining us. We're excited to explore health data utilities, or what we'll refer to as HDUs here on the show. We want to explore how they can change both healthcare and public health. But first, I want to acknowledge that healthcare has an overabundance of acronyms. I think most of our listeners are familiar with a health information exchange or an HIE, but HDU was a new term for me, so I'm sure it could be a new term to many of our listeners. And so stay tuned. We will get into the basics of what a health data utility is. But John, you've led the Indiana Health Information Exchange for years and helped stand up CSRI. How did you get pulled into the interoperability movement?
Well, if you mean in the way back, I'm kind of unique in that I can literally tell you the day and the hour when I decided I wanted to get into the health information exchange business. And it was December 2003, and I was in Chicago at a conference, and there was a guy giving a talk about what they then called local health information infrastructure, long gone term. But it was basically, what's wrong with healthcare is we've got all these silos, and it affects patients and populations and policy when we aren't sharing this information between relevant organizations in healthcare. And I'm like, you know what? That's right. I want to work on that problem. So it's been that long ago.
John, you've seen the evolution of early health information exchanges to today's health data utility conversation. What motivated you to help shape this national concept?
Yeah, thanks. Let's spend a minute on this because I personally don't think I'm shaping anything. If anything, I think I'm trying to help be one of the people shining light on this evolution, which is, I think, the right terminology. I think, and we're going to talk more about what is a health data utility and what's versus a health information exchange, big misconception. I think the reality is that as some health information exchanges many years ago started branching out and doing more things for more segments of healthcare, at some point in time, they were doing what I would call HDU stuff. And so by calling out HDU and defining it and writing capability models, we're really just, I think, pointing to the fact that at some point, what was early health information exchange that was fairly narrowly focused on patient care evolved into a lot more broader, valuable thing, and we're giving it a name.
Yeah, so for those who may not be familiar with CSRI, what is the Consortium for State and Regional Interoperability, and what prompted its formation?
Right. Thanks. So the CSRI is not a well-known organization. It's not trying to be out front. We're just trying to advance the health data utility concept and help organizations that want to be guided by that model. So our vision is that every state has a statewide health data utility. And for example, we're going to talk about the capability model that CSRI recently published, which we're basically sitting around thinking, what does the industry need to help move us forward? And we believe this model was one of those needed things.
How does it connect to the broader federal efforts such as TEF, the ONC's standards and certifications, or the CDC's data modernization strategy?
We don't control the answer to that question, right? But I think the answer is that, and it was certainly a motivating factor, as some of the health data utility leaders of the country were in dialogue with federal agencies, the agencies really wanted to be less confused about, well, what is a health data utility? And we've got people using that term in different conversations, and we're not clear what they mean. And we're not clear how that, more importantly, how that assures us that these organizations can be helpful. For example, if you're the CDC and you want information on syndromic surveillance, how do you know which organizations are ready and capable, or to what degree they're ready and capable? So the capability model, you asked specifically about the federal government. That certainly isn't the only application, and it may not even be the most important application of the model, but it, I think, is important to working for health data utilities to work with federal agencies to give them some assurance of, this is what the capabilities of my organization today. This is where we stand on different things that may be important to your agency.
So Ben, I'd love to just jump in for a second and ask John a question about CMS. I know kind of historically with the High Tech Act, there was a lot of investment to help get HIEs launched. And then obviously that was years ago, and we're seeing this evolution now. You're talking to us about it. How do you envision HDUs contributing to the work that CMS does?
I think we're learning that every agency has specific health data needs, and they've been trying for their histories to fulfill those health data needs through different approaches. We've seen many of those approaches in recent years, and there's been an evolution. Most recently, I think the dialogue, you asked specifically about CMS. We could talk about any of the agencies, but CMS is an extremely important one. I think the shift is in the federal agencies entertaining the idea that state-based infrastructure could be a key building block in meeting their health data needs. In the case of CMS, that could be electronic clinical quality measures, for example. But I think really the shift is that, you remember, we're talking to an HIE guy here, so I have that bias. But over the last several administrations, regardless of political party, HIT tends to be a bipartisan issue. Is there a lot of the policy has been based on trying to harness individual EHR instances and standards. And those are both very important things. But I think as a country, we've been missing the opportunity to leverage state-based infrastructure like HIEs, health data utilities, whatever they call themselves. That state-based infrastructure can be valuable in meeting the needs of federal agencies like CMS.
Kind of just a quick thought there. If it's done well, it certainly reduces the kind of the federal costs and overhead, while also enabling kind of more local or state or regional ability to, I guess I'd say, innovate, and also to pay attention to what matters on the ground, and not be constrained as much, as long as they're still meeting, of course, the federal requirements, but not be constrained as much by what the federal government's willing to invest in, right? I think that's one of the powers of this potentially.
Absolutely. And I've spent some time trying to imagine what it's like working for a federal agency. And you have to kind of wake up every morning and thinking about 50 states and 6 territories. And there's a desire to want to have a homogeneous solution that works for all 50 states and 6 territories. But healthcare information technology and health data interoperability is a complex issue. And that's, I think, simplistic thinking. I think we need to be able to accommodate some heterogeneity, meaning that letting states be states and letting them build that state-based infrastructure, however it's able to evolve in their state. But then the federal government saying, okay, here's what I need. I really don't care how you get it to me, Indiana, Colorado, Kentucky, whatever the state is. So that's, I think, potential power of leveraging the state-based health data utilities.
I 100% agree. And I really am looking forward to seeing how, I think, I've seen indications that this administration wants to move more towards kind of an outcomes-based approach and focus less on the infrastructure itself, but more on saying as long as the infrastructure delivers these things, which I think gets to, and we'll talk about that, the capability model and how that can support that. So I do have a kind of a quick side question. So, the CSRI has been launched. It's been around for a few years now and has evolved to the point where you're stepping back and you'll have a full-time CEO. How do you see its role evolving going forward as, HDUs mature and there's more adoption? What do you kind of envision CSRI's role to become at that point?
It's kind of like, there's that old joke about after 3 years of trying, you become an overnight success. I feel like CSRI has been sitting around thinking, working on how we can advance and influence the success of states in building their health data utilities. I really should rephrase that because I don't want to imply to anybody listening that you're going to start one day and let's build a health data utility, because very, very frequently, hopefully almost all the time, you start with the organization that is called your health information exchange or whatever it is, see what their current state is, one of the uses of the capability model, and do sort of a gap analysis. What do we need this organization to do next? But that wasn't your question. The question is, what does CSRI need to do about that? So we really are thinking about ways that we can support state efforts wherever they are on that continuum. And this is an important theme I hope comes out of this, is that one of my greatest regrets about being part of launching the health data utility concept is people immediately went to, well, I'm a health data utility. Are you a health data utility? The binariness of this is so not the point. Virtually every organization that's trying to meet the health interoperability needs of their state are somewhere on that continuum. And so CSRI wants to help each other, even the members of CSRI. I get a lot from working, talking with the Melissa Kotris and Jamie Bland and David Horax and the other members of CSRI, and we're pulling each other forward and trying to advance our health data utility in our state. So we're also like, okay, we represent a number of states. Craig Bem, his CRISP organization, is helping very directly advance health data utility in a number of states. What about the rest? How can we help any state where we're not directly active? That's what we're trying to figure out and work on.
So, Mike, before we get any more substance, I promised our listeners that we'd get to the basics. And so, John, I think this is a good time to ask, what in the world is an HDU? Let's start there, and then I've got a couple other questions to help bring our audience up to speed.
So the most concise answer is to direct folks to CSRI's website, which is the CSRI, THECSRI.org, and you'll find the capability model, which prominently figures the definition. I would encourage people not to obsess about the definition, and we could probably have an entire new podcast about the definition and how to apply it. But the answer to your question, the best I can give, is that, look, there's a continuum. If you go back to when the concept of health information exchange was invented, and by the way, shout out to the Regenstrief Institute in Indiana, which I think invented the concept of health information exchange back in the early 90s, is we focused on patients are showing up for patient care, and data needs to be exchanged from other organizations to support decision-making in that way. And for many, many years, HIE was focused on exchange of data to support direct patient care. And that's still an incredibly important thing that health data utilities do. If you look at the definition of health data utility that CSRI offers, it says that two things are at its core: health information exchange and multi-stakeholder governance. And that it's a not-for-profit organization that is focused, however, on meeting the broad health data and analysis needs of the public and private sector. And that's really the big difference between narrow health information exchange, as the world learns to think about it as supporting direct patient care, and much broader uses of health data for policy making, to employers, to support research. There's a lot of organizations that I've encountered. Some of them are like totally supportive of what we're doing, and some of them are like, your definition is wrong because, I'm a state, like here's one I've gotten is I am a state-run HIE, but I'm absolutely a healthy utility. And it's like, well, to what extent are you focused on and allowed to meet private sector needs for health data? Because often state-run health information exchanges are either literally not allowed to, for example, charge fees or do things that they would need to do to fully support the private sector. So that's not a shot at state-run HIEs. That's getting into a little bit of the nuance of what a health data utility is and how I would encourage organizations trying to be guided by the model to think about themselves and hold themselves up against the capability model.
I think that's an interesting thing you just said, John. And I know that in some instances, like a health information exchange is not, a fully public entity, that they may be a nonprofit, but they're still funded by multiple sources, and fees being one of those from private sector. At the same time, I think if you look at the utility model, generally speaking, when we're talking about like electricity or water, for example, that it does serve everyone. It's not like, the state set it up and then says, all right, now, only state buildings will be, receive electricity and water. And in that same sense, and they do charge, obviously, and some of the times that's, usually that's regulated to some extent. But I think that's an important factor that you're highlighting here as we think about this is, how do we move, whether you're fully state funded or whether you're receiving funds from multiple sources, including the private sector, how do we move forward with the idea of these are utilities because healthcare requires these utilities in order for us to be able to succeed, and the same thing with public health. Anyway, it's just, I wanted to highlight that. I don't, if you want to respond to it, but it's just a thought that occurred to me as you were talking.
Well, and not only must utilities serve everybody with, in this case, healthcare data, but also they need to be recognized as a utility, whether you take the dictionary definition of that, and we want to get some economists in the room and start arguing about what utility is. The point being, and there's different audiences for this conversation, if I'm talking to leaders of state agencies in any state, I would encourage them to really think about their health data utility as an important part of supporting society, just like their power utility or their water utility or what have you. That's one of the challenges, I believe, is that getting health data utilities recognized, not like officially recognized or designated, but to be understood to state leaders as an organization that is very important and delivering something that's necessary for society.
So, John, the other thing I wanted to ask about is just, I've been looking at the previous work that CSRI did to define version 1, which you called a maturity model back in 2023. And now you've just released version 2, which you're calling a capability model. And I wanted to ask about the change in the name. And if you could explain why that's significant, that would be awesome.
Yeah, thanks. That's an important question. So first, let me say that it's funny that the maturity model that was published in 23 and the capability model that was published in 25, in both cases, those felt kind of urgent, like the industry needed those things. And so the maturity model, first of all, the reason we published a maturity model, because it's a name that people use, right? We talk about maturity models all the time. And we really, with version 1, felt the HDU concept was just getting distorted and name thrown around, and we needed to bring give people a sense that this is a continuum and to get off the binary question of HDU or not an HDU. So we tried to get a stake in the ground. And honestly, if you look back at that, and please don't, it was pretty rudimentary. I mean, it was still a lot of work, but compared to the capability model we just put out, the new model is much more robust and useful. But I haven't answered your question yet. Why call it a capability model, not a maturity model? The reason is because the more we thought of maturity sort of has, it's not a negative connotation, but we don't want people to think of, well, if I'm in an early stage, immature or, behaving like a teenager or whatever, the real focus is on the capabilities. If you're talking to the CDC about, and they want to know if your organization can help them or not, they don't care how mature you are. They care how capable you are. And so really, we just wanted to put the focus on the fact that this is a model to help steer organizations towards what their capabilities could be, should be, to broadly serve all these segments that a health data utility should be thinking about, and to help gauge where they currently are and communicate that capability level to the industry.
Yeah, and I taken a look, in spite of your joking that we shouldn't look at version 1. I took a look at version 1, and I can really attest to what you say, that version 2 has expanded on that significantly. And I think some of the things that really I'd love to hear more about is you've kind of expanded on the public health side. You've added some, I guess I'd call it, you call them gates, but kind of foundational things that are required in each of those domains that you support. So could you talk a little bit about those changes and what motivated them?
Sure. Well, as we were talking to different stakeholders, and importantly, using there's so many places. If you wake up one morning and you say, what are all the documents that have ever been published or available resources that can help us think of all the things that a health data utility should be capable of doing, then you end up reading and finding a lot of documents. And as we really started making it more robust, we had to pare down the capabilities that we used in the model, because there's so much out there, and you really have to have arguments and discussions about how, things that, well, everybody should be capable of that. Well, yeah, but that's really hard. So we can't expect people to have that on a most basic level. That's all hard enough. But then when you realize, okay, people are going to need to be able to use this model to score themselves or to be scored by some accreditation body. And that makes it way harder. And I'm sure we don't have it right yet, by the way. We're in a comment period right now, and really important that we are listening to people who didn't have an opportunity in the creation of the model to provide input, and some who already did, to feedback on what we got right and what we got wrong. But for your example of the gates, really, really important. These are like particularly essential capabilities at different levels of the model that your organization needs to have to be scored or at a certain level, and to be able to assure the industry that they are capable at that level. And I will tell you, there are gates in the model at reasonably low levels that I've pointed out to my own organization. Guys, we don't have that yet. So we can learn from, builders of, I didn't sit around making up this model. We had a lot of people working on this with input from the industry, and they thought there are things that are important that my organization doesn't have built yet. So we got to get on it.
It seems like this can be kind of a way to have a conversation about roadmaps and about future development with maybe state legislators or policymakers. How do you envision this? And you mentioned the private sector as well. How do you envision this being a help to states, to policymakers, to private sector leaders?
Yeah, that's going to be, and that's one of the things I like is it's going to be different in every state, and the way it's applied and the set of circumstances is going to be different in every state. But so let me give two examples. Let me give an example of a state where maybe they have a fairly well-established health data utility, but they aren't recognized as being that important utility to society by their state government or by their state leaders. They can use this model and the definition and, frankly, a lot of the things that are being published about health data utility to help make their case to state leaders to say, this is important. We want to support your state agencies, but you also want to make sure we are appropriately supported by state government. That's one example. Another state may be the state leadership is like, hey, I've heard about these health data utilities, and we don't seem to have a good one in our state, and this seems kind of important. So what organization is the best base on which we can build to make sure that the state that we're in has a good health data utility? So that I see the state leaders taking this model, approaching their hopefully existing not-for-profit health information exchange and saying, hey, are you guys being guided by this health data utility model? We'd like to build this capability in our state. How can we work with you and support you in moving down this continuum?
Yeah, that sounds great. That's very exciting.
Yeah, I think that's a great segue into my favorite part of the show, which is to discuss the impact. So let's talk impact for a minute, John. How do HDUs, or how do you see health data utilities transforming healthcare delivery and financing?
This is probably a good time for me to acknowledge I'm going to start saying a lot of Kansky opinions.
That's fair. We invited you.
Yeah, but it's so I'm taking off all my hats. So again, I love the fact that every state's different. People are the health data utilities are not going to have all the same shape, and they're not going to be funded the same way, and they're not going to have the same capabilities. But they should all be focused on the things you just said. How do we make healthcare better and of higher quality and safer and cheaper and faster? Kansky's opinion. If you look at the mission statement of my organization, that's basically what I just said is through health information exchange, improve the efficiency and quality of healthcare. But how? Again, invite me back for 3 more podcasts and, we can explore that in detail. But the reality, if you think about it, let me finish that thought and then go on to another one. The reality is if you think about what do we need health data for? If you're a policymaker, what do you need health data for? If you're a doctor seeing 22 patients today, what do you need health data for? If you're a hospital CEO or CFO, what do you need health data for? There are big, robust answers to all those questions, and they're all different. So health data utility, like, for example, if I'm talking to my state Department of Health, it's like we get up every morning trying to be the place you guys can go for the data you need, period. So you can be in the public health business, not the how do I get data business.
Right.
So that we can be the answer to that question. And then the other thing I was going to pivot to, and this is, I don't know if this is interesting or not. You can edit it out if you think it's dumb, but I went to school to be a biomedical engineer. And I thought I was going to, if you guys are Monty Python's fan, I thought I was going to make the next machine that goes bing at the bedside that was going to, help save lives or whatever. And as I started my career as a biomedical engineer, it was really obvious thing that was affecting the quality, cost, and in some cases costing people their lives in healthcare was information.
Yeah.
It wasn't where it needed to be, or it was wrong when it got there. And so I really kind of tried to pivot my career around to information as the key thing to help healthcare. And I'm still here.
I'm going to put you on the spot, John. You mind sharing an example? It could be from Indiana Health Information Exchange or other states where statewide data integration improved care coordination or value-based payments.
I don't know if this is an example that scratches the itch of the question that you just asked, but here's what you made me think of. So one of the frustrating things about being a health information exchange is that it's hard to prove the negative. And one of the things that you do every day is you're saving money, you're saving time, and you're saving lives. You just don't know when you do it. So when we are given examples from somebody like a story that says, hey, I got information from the information exchange and this thing happened and it made a difference, we really take those things to heart. Once upon a time, we were running a program that helped physicians be aware of gaps in care. When, for example, when some of their patients had colon cancer screening at the appropriate time and some had not. And when they hadn't, we would make them aware of the fact that, hey, here's your 11 patients that haven't had their colon cancer screening. And we had a physician tell us that 3 patients were with care gaps, had their colon cancer screening and were diagnosed because of that and could have had a role in saving their lives.
Yeah, it sounds like health data utilities are an incredible asset for both health systems and payers. Are there any other problems that HDUs uniquely solve that we haven't touched on yet?
Again, I keep saying the same thing over again. 3 more podcasts.
We're going to have to invite you back, I think, John. We're going to have to invite you back.
Yeah, I love this stuff. I love the opportunity to share ideas. So I appreciate being invited. Some of the answers that come to mind, maybe on the extremes. One is academic research, incredibly important. I think a lot of academic research in healthcare, in my experience, is being done with just minimal data that they can scrape together, the researchers. Indiana, our health information exchange is somewhat unique in that it was formed in the mid 1990s with research as one of its focuses from day one. That's pretty unusual. But so research is one of the answers to your question. But going maybe to another extreme is policymaking. I think public health decision makers and Medicaid decision makers and those setting state policy are doing so with not nearly the information or analysis about the populations that they're trying to help. They could have through their health data utility. I've certainly had conversations with legislators trying to make them aware that our organization exists and what we do. And they're like, could you tell me this? Could you tell me that? And sometimes the answer is yes, and sometimes the answer is no. But even when it's no, it's like, I didn't know it would help you to know that. Let's think about how we collectively can make sure we have the data to answer your question.
So, John, another important question that I'd love to hear your thoughts on has to do with the business model behind HIEs. As you know from your long involvement, like one of the most important things, probably the most important thing for an HIE to be able to thrive is to get that business case right, to get its sustainability model right, and to get the right people involved. How do HDUs, or the concept of HDUs, how does that help, or how does that affect the business case?
Sure. And our listeners may already be aware that and in this case, it doesn't matter if I say HIE or HDU, the answer is the same, how those organizations are currently financially sustained in their respective states. It differs greatly. Just did a presentation at the last Civitas conference with Dr. Julia Adler-Milstein, who's well-known, University of California, San Francisco. She's a HIE researcher. And we did some analysis on what HIEs cost per capita, but also shine some light on the differences in the level of government funding, which is really where I was going in the answer to your question. There's sort of an evolving, some of us have been saying this. I have certainly there's an evolving rule of thumb that HIE should be funded like a third from providers, a third from payers, and a third from government. I don't know that anybody's really validated those fractions. I think the concept is important. And there's some talk about extending that research to look at stuff like that. I think the reality is that to the organizations that the value accrues, that have the ability to pay, they should help fund the organization. And if you're in a state where through that research, the top 20 health data utility organizations in the country, measured purely by their financial size, which is a terrible way to measure the organization, are 56% government funded on average. Average is the dumbest thing I said in that sentence, because the variability in the level of government funding between those organizations is like 2 to 98.
Oh, wow.
In terms of their government funding. Okay. So we don't have the mix right. But what is absolutely clear, if we go back to the idea that a health data utility is for everybody and is an important asset to provide health data for society's needs, then governments want to make sure their health data utility is well supported and capable of doing what it needs to do. I don't think 98% funding or 100% funding or 75% funding from government is a good idea, because I think that it's really important that health data utilities are supporting the private sector. What does that mean? Insurance companies, not-for-profit health systems, for-profit health systems, providers, all of the above, employers. And if any of those organizations are getting value, they should be willing to pay their fair share of covering the cost of that organization's expenses to produce that value. So I'm probably over answering the heck out of your question, but this is one of my favorite topics. So clearly, in summary, it should be a mix of the private sector organizations that are getting value, compensating or covering costs, and government as well. If they're receiving value and want to make sure that they have a healthy health data utility to support their populations, they should be providing funding as well.
That's great. I kind of wanted to move, you talked a little bit about public health in your answers to Ben, and I wanted to talk a little bit about that as well. as I know you're aware, there's been kind of a movement within the CDC to look at, how they might be able to use HIEs or HDUs as intermediaries between healthcare and public health authorities, whether that's statewide or regional or local, or even kind of rolling things up eventually to the federal level. And so I'd be curious about how this evolution better supports that, and kind of what your vision or maybe CSRIs, if you're able to speak for them, what the vision is for how an HDU can contribute as an intermediary between healthcare and public health.
So first, let me acknowledge the CDC in that question. The only reason that health data utilities should be valuable to meeting the public health information needs of the CDC is because they're valuable and focused on and investing on and working on meeting the needs at the state level and the local level for public health. I want to make that point clear, is that if you're a health data utility or you're an HIE, you should be waking up every morning trying to support public health needs at the local and state level. And because as organizations we're doing that, we're accumulating not just data, but knowledge and trust at the state and local level. And that gives us data assets and capabilities that can be aggregated to meet the needs of, for example, the CDC. The origin story of CSRI. Where the heck did CSRI come from? Before there was a CSRI, ONC saw several state HIEs putting out COVID dashboards. They said, wow, these are kind of impressive. Can you guys do this for a national dashboard? And as you can imagine, if you know anything about health information exchange, the answer is not tomorrow. But yeah, so several, phones started ringing, and I got a call. I think it was from David Horrocks in New York. And they're like, hey, some of these organizations are trying to react to what ONC asked for and demonstrate that we can at least do a multi-state COVID dashboard. In 3 weeks, we had a 6-state dashboard.
Nice.
ONC said, that's pretty cool. What could you do with a little bit of money and a little bit of time? And that ended up being a 22-state COVID dashboard. And when we saw that we could do that, that was really the origin story of CSRI. It's like, we've got to do more stuff like this, whether that's advancing the capabilities of health data utility or figuring out how they can do things together that help at a regional or national level, or just advancing more organizations to be able to join that. 22 is great. 50 would be better. 50, 60 would be great.
No, that's fantastic. And I think that story is both, it's impressive in that it illustrates the power of using data that is being captured kind of locally within the state without trying to create a separate infrastructure to pull all that together. It's also
a separate redundant infrastructure.
Redundant. That's a good point. And then I think there's another factor here that may be a hypothesis more than a proven fact, but I also suspect and would love to learn more. I mean, if you have facts on this, I'd love to hear them, that it also decreases the marginal cost of collecting data for public health, because it's being collected already for healthcare as part of delivering healthcare. And ideally that, there's still a cost, I know, to transforming it for public health, but ideally that cost is, marginal cost decreases. I don't know. Any thoughts on that?
Yeah, this is a super interesting space, and I'll make the argument on both sides. On the one side, something we experience on the ground is that data streams that are designed to support healthcare are reusable for public health, but sometimes they need modification or enhancement. And sometimes the gears grind a little bit because the public health people are like, well, we saw the lab message that the hospital sent you for their purposes, and it's not completely suitable for our purposes. And that's a learning. And those organizations all need to collaborate to address that. But you really asked a question that more macro, is there evidence there's, cost that can be taken out of the system by leveraging state-based infrastructure? I cannot quote you numbers, but we can certainly point to any number of examples. Anybody who's listening to this who spent their life in public health knows that what I'm about to say is true. And it's that when the federal government has funded asthma or chronic disease or diabetes. They create rules for that funding that force there to be silos. So the state departments of health I can only spend this money on diabetes. So I have to create a thing or buy a thing that helps make a database for diabetes. And the asthma people are over there going, well, I got a different grant to do asthma stuff, so I'm going to do that. So whether it's by design or as a unintended byproduct of the way that the system has been funded, we've created a lot of national siloed efforts and siloed systems in public health that are narrowly focused on one thing. And you can see the danger, just ineffectiveness of siloing the information. But then if you get out, you get the accountants involved, there's a lot of redundant cost in doing things that way. And if we can take advantage of state health data utilities that have already figured out how to cover most of their costs before the federal government says, hey, here's some money to help meet my needs, you can see how the government would be getting value for, a fraction of a dollar. They get a dollar's worth of value for a fraction of a dollar of cost.
Yeah, that makes a lot of sense. That leads to my kind of last question in this area. Like you mentioned about how there is some difference and still some discussion to be had at times between using kind of the lab report example of this is what you get for healthcare, this is what I need for public health. The other thing that I think is critical is kind of the timing of things, of course. When you're doing healthcare, you want your information to be valid and validated and to have, very high confidence that, what you're receiving back from the lab is correct. When you're looking to kind of monitor and detect from a public health perspective, you're not as concerned about perfection as you are about timeliness. So there's sort of a trade-off there. I'm wondering if, as you think about, the future of HDUs in health, in public health, like what are some other changes that may need to occur to enable that to really take place?
Well, let me think about while I'm answering, because when I'm listening to you, first thing I want to point out is that in public health, a lot of times it's absolutely the other way around, is that healthcare is happening closer to real time. Public health folks would be happy to know what happened last month, and they may be using claims that are, sometime, or BRFFS, if you know what that is, that's phone surveys, guys. They're calling up people who don't even have landlines anymore.
That's fair. That's fair.
Trying to ask people to gather data about public health. Are you kidding me? So, we can tell public health folks what's happening, last hour or yesterday or last week, and not having them trying to rely on whatever it is, old claims data, or again, like the researchers, whatever data they can scrape together. So I really feel like what needs to be changed is dwarfed by what already exists that we're not taking advantage of. I don't want to get too specific, but one of the challenges there's an initiative going on right now in Indiana in the public health space that I really feel like the public health, I have to find a way, our organization has to find a way to get the public health folks to understand the depth and timeliness of the data we have available for their initiative they may not be aware of, and they're thinking they don't have data that they could have.
No, that's exciting. I'm glad you flipped it around because certainly as kind of, I work in this field as well, I also have that perception. And so it's good that you're tackling those kinds of perceptions to help people to understand that timeliness may not be the issue and that the data may already exist and be accessible. Yeah.
Awareness is, I had a conversation with a state legislator recently, and they're like, and what's your ask, Mr. Kansky? It's like, what my ask is? Remember that we exist. Because my greatest fear, whether it's in a health system or in a public health discussion or a Medicaid problem conference room, is that people are discussing an issue that the health data utility could absolutely be valuable in helping, and nobody in the room knows or thinks of us.
Yeah. Yep.
So, Mike, I've been sitting here listening and taking it all in, but, and John, we've gotten a little bit into your origin story earlier, but wanted to ask you what personally drives you in this work, and looking back on your time helping to start CSRI and advance this model, what are one of the things you're most proud of?
It's nice to get up every morning to go to work and to kind of believe that because sometimes it's stressful and sometimes it's not much fun, but it's so much easier to get up in the morning when you believe you're doing something that's trying to improve the health of humans, whether that be one individual at a time or a population. I'm sure there's people that are perfectly happy with their jobs selling carpeting or whatever it is that they do, but this is what makes sense to me, and I can't stop doing it.
And something you're most proud of?
Probably that at the points in my career where I had to choose between the path to do what I just said and maybe the path that would have been a little bit more financially beneficial to John Kansky, I have pretty consistently chosen the path that, hey, I don't have any trouble feeding my family or sending my kids to school. I've been compensated well enough, but put the focus in my career on trying to do the same thing that all the not-for-profit HIE leaders are focused on, right? We could probably all be doing other things on the for-profit side, but we made other decisions.
I don't think there's anything wrong with that answer. What do you see as like the next frontier, either for Indiana Health Information Exchange or for yourself in this movement?
Well, let's not talk about me. Let's talk about, because there's so much going on. I think there's a giant question to be answered. We touched on it earlier as to whether the federal government places belief in the idea of using state-based infrastructure and steers policy at ASTP, ONC, CMS, HHS, FDA around to taking advantage of that state-based infrastructure. I think it's a forefront right now, and the answer to that question is going to be really, really important.
Yeah, so I think we've got some listeners that have learned a lot today from you. And I know you shared the website earlier, but for anybody who wants to follow your work or connect, what's the best way for them to reach out to you? Is it LinkedIn? Is it through email?
Yeah, my email's not well hidden, jkansky@ihie.org. LinkedIn, I'm easy to find there too. And info@ihie.org if you can't remember anything else. But yeah, I love talking to other leaders in this space. And we've talked about CSRI quite a bit. That's my squad. It's incredibly helpful to be able to have strong relationships with those leaders and others in our industry. Yeah, reach out.
Yeah, thanks for sharing.
So, John, before we kind of close out, one of the things we always like to do is kind of ask, what can our listeners do? So first, I'd like to kind of start high level and just ask, what would progress on this concept look like over the next year if the community, and by community, I think we can be broad about that, could be, state, federal, the HIE, HDU community, and the private sector. What would progress next year look like if that community really engaged?
Yeah, I think the greatest opportunity for progress is probably with state leaders, whether those be in the health data utility organizations or in the agencies, to embrace the idea that every state should have a capable health data utility and to start from where you are and make it better. And I don't care if you're in Indiana or someplace that is starting from a different place. I think the biggest opportunity is try to get all 50 states moving in that direction, guided by this concept of the health data utility and measured by the capability model. But there's many more answers to your question. If you're a health system leader, there's value your organization is accruing that helps it save money, has economic value to your organization. But also, if you're a not-for-profit health system, read your mission statement and you'll understand that you also need to help ensure there is a capable health data utility in your state. I could go on, but I think those are two good examples.
Thank you. And then for those who want to do something right now, I know you mentioned earlier there's a feedback period. I believe that ends on December 12th. Is there anything you want to say about that? Just how they can get engaged there?
Yeah, if this is getting out in time, it would be great for anybody who's interested in or expects to be or is guided by the health data utility concept. Dig into the model at whatever level you're capable and feedback to us on, hey, that seems to make a ton of sense, but that doesn't, or this capability is missing, or this one's too low in the model, whatever comes to mind. But we hope that this becomes the industry accepted model that may lead to an accreditation process. And we want it to be beat on by industry people so it can be ready for that day.
Fantastic. Well, thanks, John.
John, thank you for joining us today, and thank you for your leadership in defining what health data utility can be. We encourage everyone listening to learn more at thecsri.org and share your feedback on version 2 if you have any. We'll include links in the show notes for CSRI, Indiana Health Information Exchange, and upcoming HDU discussions. This concludes another episode of the Next Orbit podcast. We'll see you on the next one.
The Next Orbit podcast requires more than a conversation. It takes action, research, and collective wisdom. If today's episode resonated with you, we'd love to hear your insights. Join the conversation and help us shape the future together. We'll be back with more stories, strategies, and real-world solutions that are making a difference. In the meantime, be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.